Welcome to the Dusty Muffins, where menopause meets sisterhood and strength. We're three menopause specialists coming together to laugh, share, and empower you through the wild ride of menopause and perimenopause. Whether you're curious, confused, or just looking for real talk, you're in the right place. We're here to answer your burning questions, educate, and advocate, all with a dash of humor and a lot of heart. So pull up a chair and join the conversation. Before we dive in, please remember, while we're doctors, we're not your doctors. This podcast is for educational purposes only and is not a substitute for medical advice. We encourage you to partner with your own medical clinician to address your unique health needs. This is the Dusty Muffins. I'm Dr. Rebbecca Hertel. I'm a board-certified osteopathic family medicine physician and a Menopause Society certified practitioner. I have a private telemedicine practice, and I see patients in several different states.
I am Dr. Aoife O'Sullivan, a board-certified family physician and Menopause Society certified practitioner, and I see patients through my telemedicine practice here in Oregon and Washington.
I'm Dr. Hart Kress, a board-certified women's health nurse practitioner and menopause certified practitioner, and I see patients via telemedicine in several states as well.
Lauren Tetenbaum is a licensed clinical social worker, women's rights advocate, and writer dedicated to supporting and empowering women through life transitions. With experience as both a lawyer and a psychotherapist, Lauren specializes in counseling women navigating identity shifts related to motherhood, career, and reproductive health. Lauren frequently contributes thought leadership to media and professional organizations. She's the author of the acclaimed 2025 book, Millennial Menopause, Preparing for Perimenopause, Menopause, and Life's Next Period. Learn more about Lauren at thecounselor.com. Welcome.
Thank you. And it should be said that Rebbecca contributed so much to my book and my education, and I'm just so happy to be here with all of you.
Oh, tell us how you two got together and how you met and started working on that.
Sure. We met at an event August 2024. It was with Dr. Heather Hirsch, and I was in the throes of researching and writing for my book and wanting to connect with as many experts as possible. And as you know, Rebbecca is so generous of spirit, and we became friends, and she truly was always there for me whenever I had a question. So I'm always very grateful to her.
Oh, we love her.
Yes, she's a good one.
It was so much fun. I really enjoyed it, and just felt honored to be asked to help help through it and give you information when you were needed. But yeah, so it was in New York City at one of the events that Natalie and I had gone to, and it was just a very nice, intimate event. And so we met at the end of that, and so that was really fun and just hit it off. And so it was really just amazing to watch that book come together and then now just flourish. It's awesome.
So, Lauren, what inspired you to write Millennial Menopause? Was it personal experience or some aha moment that led you to this work?
It was an aha moment. I have always been passionate about women's rights, women's health, about supporting women. And I have been working as a therapist specializing in perinatal mental health. I work with a lot of women in their 20s and 30s. I have young kids myself, and I was about to be 39 and went to a networking event with Ann Fullenwider, who's the co-founder of Alloy. Everybody in the room was older and saying things like, I wish someone had warned me about menopause. I wish I had been offered information and resources. I wish I had been taught that it can last for a decade, all of the symptoms. I wish someone had told me. And I truly walked out of that event thinking, well, I'm going to tell all of my peers, my clients, my friends, learn for myself. And I started writing and asking questions and ultimately got the opportunity to write the book.
It must have taken a lot of research because there's a lot of dodgy information out there. There's some good information out there.
Yes. So as a former practicing attorney, I am very careful about what I am claiming is accurate, and the end notes are tremendously full of citations and resources and well-vetted resources. And it did take a while, but I love to learn and to connect with other providers who care about this. So it wasn't just reading scientific academic journals, which I did, but a lot of conversations, podcasts, etc. And I feel like I was able to give all of my readers the right information.
Yeah, and there was a lot of quotations in there too from a lot of menopause practitioners, women, clinicians, experts in the space as well, which is really great. But I want to know about your formal life, about being an attorney, and how did that transpire to then leading? Did that lead into social work and doing that part of your life, or kind of how did all that come together and change?
So yes and no. I went to law school to advocate for women's reproductive health. I took a class in college about reproductive rights in the law, and I had an aha moment back then. I thought, okay, I want to advocate for women. Let me go to law school and do that. Well, I hated law school, not going to lie, but I stuck it out. I also simultaneously pursued my MSW because I really love working with people directly, and I love mental health, and that compassionate lens I felt was a good complement to my legal education. I worked in law for 10 years, during which time I had kids, and towards the end, it was COVID, and I was truly looking around thinking, even though we have privilege, we have health, my community, my friends, our mental health is in need of additional support. And I thought, I have the ability, I'm a licensed social worker, I have the ability to provide the support I wish I had had. So I pivoted, I became an entrepreneur, which I never thought I would do. I started a private practice, and now I counsel women in their 20s, 30s, and 40s on anxiety and depression related to all of their stressors, including their reproductive health.
So you did your MSW as you were doing law school? Oh my
Yes, I
God.
did both within 4 years. Yeah, as you can tell, I I like to learn.
Did you say
Nice
you
learner.
did in 4
Yes.
years? Yes. Wow.
Yeah. Thanks.
That's crazy business.
Yes, and I was
Amazing.
interning, and yeah.
No wonder you and Rebbecca get on so well.
No,
That girl would
I don't
We
know if
like
I
to be
could do
busy, I think.
So
just
what has
even
the
now.
response been now that you've been on your book tour? What's the response been to the book? I mean, the title is absolutely brilliant.
Oh, thank you.
What made you pick that? And are you finding younger women are coming to meet you on your tour?
They are. I would say that the sweet spot is the eldest millennial, the women in their mid 40s, because they are feeling the symptoms and they're very curious and they know how to use social media and all these digital resources that we now have. I would say that the younger millennials, so millennials were technically born between 1981 and 1996. So the youngest are 29 or, in their early 30s. They tend to hear the word menopause and get scared, which actually is the point of the book. We shouldn't be scared. It's inevitable. It's okay. And knowledge is power. So even if we might experience difficult symptoms. Knowledge is power. And here's literally a list of resources at your fingertips if and when you need them. And I hope that more women who are younger do realize that, but I like to advertise the book as for millennial women and anyone who cares about them.
I love that. I love that because then a mother and a partner could be encouraged to read. You'll be happy to know because nobody on social media believes it unless the Menopause Society says it so. But they did talk about perimenopause beginning in the 30s, which so many women go to their providers and they'll say, no, that's too early. So now the Menopause Society has said it. It was in a lecture. So maybe our younger patients will get a little less gaslighting when they go into see those providers. I thought it was interesting. I mean, we've known that.
Right.
Those of us really in the space, but not your typical OBGYN or primary care when we're seeing patients in practice. So I thought that was interesting.
Even their guidelines a couple of years ago said at age 35, start the conversation just so that women get educated. But I read those guidelines at age 40 and I'm looking around like, none of my doctors ever mentioned anything to me. So I do think it's important. And also as a mental health provider, we know that many of those early symptoms are actually mental health related. Mm-hmm. It's not the irregular periods necessarily. It's the mood symptoms. And we really just need to be in tune with what the women in front of us, our patients, our clients are telling us.
I mean, for those of us who got any teaching at all in menopause, it was all about hot flashes and night sweats, right? And when you actually look at your patient, that's way, way down the list. And they are brain symptoms, but most of what we see are other brain symptoms, right? The mood and the low energy and anxiety. When you see patients, Lauren, the patients who come to you, what kind of symptoms are you seeing when they come in?
Want the Dusty Muffins at your next event? We do panels, live podcasts, and talks that bring the heat, literally. Corporate, see-me, or retreats, we've got you. So hit us up at thedustymuffins333@gmail.com or DM us on Instagram at thedustymuffins.
A lot of rage.
Yeah.
A lot. And rage shows up in the perinatal period as well. A lot of women don't identify their anger or irritability as depression or anxiety, but surely it is connected. And I like to treat the symptoms, not necessarily the diagnosis. So it's been interesting as I've grown with many of my clients who I did treat for postpartum depression, for example, or, anxiety, generalized anxiety disorder, adjustment disorder. They are now coming to me with new symptoms. And they even say, this isn't my usual moodiness. These aren't my usual symptoms. All of the coping mechanisms that we've been working on that I felt good about are no longer working. And sure enough, we do some digging and then there are other perimenopause symptoms that come to light.
Absolutely. Like having been in primary care for many years, the anxiety and the depression that show up in perimenopause they have a different flavor, don't they? Yes. They are just different. Yes. We were talking in one of our last episodes about Dr. Kulkarni over in Australia, who created a questionnaire called the MenOD, which is slightly different to the PHQ and kind of pulls up more perimenopause symptoms.
Yeah, I'm surprised that the PHQ is still what the Menopause Society suggests. And also, providers, as you know, need to understand that these tools are just screening tools. We then need to do something with the information that we gather. And they might not meet the criteria for major depressive disorder, but they still deserve support. So yes, it's a tool, MenOD, PHQ-9, whatever, but it's just a tool in our toolbox.
Mm. And, you actually, all the different hats that you wear, and as a mom as well, how do you kind of blend everything together and how does it all work for you?
I tend to have busy periods and then take breaks. So for example, this upcoming week, we're recording in early November. I'm not sure when it'll be released, but I have events in my town in New York City, and then I'm going to Miami. But then the week after, I am chilling. So I have a wonderful partner, my husband. He's in the other room. Maybe he can hear me. And he is very much a partner. And I also have a beautiful community, my community of girlfriends, mom friends. I couldn't do any of this without them. They come to my events. They are cheering me on. They're introducing me to their businesses where I come in and do corporate trainings. And of course, they help with carpool. So I'm very grateful for them.
I know. I think we all depend so much on our girlfriends now during all of this, don't we? And we're all kind of going through the same issues at the same time.
Yeah. And it's so important and amazing to be able to have that community and to laugh at the stressors that we all experience and have a bit of lightheartedness.
Yes.
Yeah. I mean, I think, the last 3 years, there's been more momentum to destigmatize menopause. And I really think that the millennials, could be the voice of change. And, I think they could, change the narrative, especially those younger ones. I mean, they're never going to not have knowledge.
Mm-hmm.
They're hearing it now. I think, what's your thoughts on the millennials and why you targeted that group, right? So what do you think? How do you think the millennials can really reshape how we approach menopause care in the future?
Sure. So I targeted that group because I am smack in the middle of the millennial generation. I'm born in 1985. I am 40. I'm super millennial when it comes to pop culture and just the way I grew up. And so I incorporate a lot of those references in the book. It's a fun book. There are Mean Girls references right in the beginning. You know, it's like I said a minute ago, we have to take things lightheartedly. I really believe that. And that helps it be less scary. And I think that millennials are good at that in general. We are comfortable talking about things like fertility struggles or mental health or the stresses and the mundaneness of motherhood. And we are comfortable demanding better. I hope that we continue to be more comfortable because there is still a lot of work to do. And it's not like we've solved the, maternal mental health issues, but we are more comfortable talking about it. And I believe that the narrative changes when we start talking about it. So I've always been very open about reproductive health and rights. In college, I was in the vagina monologues. I was screaming vagina in the middle of campus. I was known as Condom Girl in law school because I was doing fundraising for sex education programs. So I think, not everyone needs to be yelling vagina in the middle of the field or the path. But we have to be talking about these things because they're normal. And that's what creates change and access to resources.
Mm. And when you see patients, Lauren, and you're working with them, especially with their mental health, do you have other healthcare professionals then that you can refer them to if they're interested in hormone therapy, or have you kind of built a network for yourself?
Absolutely. And that's been such a highlight of this work because I've been able to connect with other practitioners, whether they're local, I live in the suburbs of New York City, or they provide telehealth. And they can be doctors like yourselves, or nutritionists, or fitness trainers, or sleep psychiatrists, or reproductive psychiatrists, or bone specialists. There's such a wide range. I believe that perimenopause, menopause is an opportunity for collaborative care. And I recently got my MSCP, which was super exciting because I felt like, thank you. I felt like I knew my stuff. And though I can't prescribe, I wanted to demonstrate that I really am up to date with all of the latest research in this space. And frankly, to vet other professionals who I want to make sure that if I'm referring someone, that they are really modern and collaborative and open-minded in how they treat women, because this isn't a one size fits all, and it's not a one-time visit that can fix things. This is an ongoing way to care for a woman. So we all have to be on the same page, I think.
Yeah, it's a nice team approach, right? We talk a lot about, needing a team and having, other practitioners, clinicians in this space. So, if we're doing their hormone care, we have someone helping them with their mental health, and there's somebody helping them with their fitness and nutrition. And so it's really nice to have kind of just that team approach with patients. And they seem to really like that and enjoy that as well.
I think so too. And I mean, I'm a patient also, right? We all are. And I appreciate that approach as well.
And I think one of the things that, is confusing, and we were talking about this before we hit record, is sort of the landscape of how to treat perimenopause. And I know for myself, my first few perimenopause patients, I thought I was going to lose my mind trying to figure out how to manage them, because there's not a lot of information out there beyond put them on birth control pills. And in the Menopause Society meeting last week, there was not support for doing much else. They said you could. However, they said you shouldn't give them just progesterone. Progesterone doesn't help with sleep, which they said last year as well, which tell any perimenopausal woman they don't sleep better on progesterone and they're going to punch your lights out.
Mm-hmm.
And they said mood was And so I took away from it, and maybe Rebecca, Aoife, you took away something different. You know, that outside of birth control pills, they really were not helping clinicians learn how to treat perimenopausal women with MHT, and they for sure did not support testosterone in perimenopause, which the guidelines don't support either. But we all know from clinical practice that, you know, progesterone's a game changer, and a little bit of testosterone is often all most perimenopausal women need. But, you know, I understand why there is so much confusion, and they really did make me second guess how I practice. But I know the things that I do give great outcomes, but there's not randomized controlled trials. And, you know, that's what the academic educators at these conferences are looking for, which I'm just going to mention are so deep in bed with pharma, with a list of disclosures greater than my arm for, you know, fezolinetant, isozolinetant. And that's what, and who were big sponsors as well as Bayer. And man, those products, front stage, prescribe all the non-hormonals, which, by the way, you can't prescribe in perimenopause either, according to the research. So I don't know. What do you ladies think about that? It drove me nuts when I got home. I really had to rethink myself.
Yeah.
And not
I just kind of ignored that for my own clinical practice. But here's where I struggle. I think the struggle is the different things that perimenopausal women are hearing on social media, and how their true understanding of what the ovaries are doing and the brain is doing in perimenopause. Because for some, shutting the ovaries down does make them feel better, or those who are on birth control, they feel great. I think that the hard part is really teaching them that menopausal hormone therapy is not going, it's a cushion. It is a support. It is not going to stop the ovarian high estrogen levels and the drops and things like that. And so in my practice, I feel like my women sometimes feel like they fail because they're not feeling better. And really it's because they're so volatile and they're having so much fluctuation that they don't understand that you have to change that. You know, we're going to have to change the estrogen and progesterone. And some days it's going to be too much and you need to pull your patch off or whatever. And some days you're going to need a little bit more. I think that's what's lacking, because in social media, they're hearing, yeah, you can use menopausal hormone therapy. Why not? And it's bioidentical and it's, you know, made from plants. So they want to stay away from birth control. But I think the true issue is these poor women really trying to understand what is happening with their brain and their ovaries. I don't know. Do you think that's what I'm seeing?
I've been thinking so much about this. And I think part of the problem for the patients, for the women, is that we want to feel better and we want to feel better immediately. And the reality of it is that this doesn't work like that. And I get it. We are all so tired. No one wants to add this BS to our to-do list. If the plan is to continue to have frequent check-ins with our providers, how do we even find a provider? The guidelines are changing, new drugs, old drugs, you know, it's overwhelming. But this does involve trial and error, patience, self-compassion, hopefully a support system at home, hopefully flexibility at work to attend those doctor's appointments. And again, providers who really know what they're talking about and will collaborate with you. So I get it. I wish there were, you know, one drug or whatever it is to fix it all. There isn't. But knowing that, how can we find the best collaborative care team to go through this journey with?
Struggling with mood swings, low energy, weight changes, or feeling dismissed about your hormones? You're not crazy. You're in midlife. I'm Dr. Rebbecca Hertel, board-certified osteopathic physician and certified menopause practitioner. And at Osteopathic Midlife Health, I offer personalized concierge telemedicine for women in multiple states, helping you navigate perimenopause and menopause with expert care focused on hormones, weight, sleep, libido, and more. My approach blends evidence-based medicine with a deep understanding of longevity and precision in midlife health, because this phase isn't just about getting by, it's about thriving for decades to come. So visit www.osteopathicmidlifehealth.com and let's build your roadmap to lasting vitality.
And really understand what's happening with your body. I think, because when I get like that, you know,
graph out and show them like, this is what your cycles used to be before you hit perimenopause. Just this really nice, like EKG type, graph. And this thing 1 month might look like this. The next month it might go back to normal and you're perfect. And then, and it changes as you are getting into that as you go through that perimenopause transition from early to mid to late, and then into early menopause. And so I know at least I think if we gave women, if we really focused a lot on teaching us, I mean, half of us weren't even taught really what our darn regular cycles are supposed to do.
Oh,
and
no,
now
no
we're,
one knows
supposed to think that they understand perimenopause and for that to work. And so, yeah, I think that's where sometimes I think that's where our older colleagues love the birth control pill. They're saying, yes, this is what's going on. And this is why you feel terrible. So let's just shut it all down. That's one option.
Right. There's so many options. And again, it does take that patience, which I'm not a patient person. I get it. But I recommend it.
You really hit that. It is the patience, because how many of us have had patients that after a week of putting them on something, they're like, I feel terrible, I'm ripping it off. Or I upped it to here, or I downed it to there. And you're just like, oh my gosh, we didn't even give it a chance to work. And it's because they, they're scared because if they don't feel good or they don't know what's going on. And I think when you have that underlying, starting with that education of this is what happens in perimenopause, and then it's funny because you'll do the lab work and their estrogens, 240, 500, 600, 700. We're like, yeah, that's why you felt like crap. That's why you were bloated. That's why you were retaining water. That's why your boobs hurt, is because your estrogen was super high. And I can't control that on menopausal hormone therapy. But I think if we give them a really great understanding of what it can help them do and can help with, and the pros and cons between both, I think that's helpful. But I really think that educational piece around what is happening to our brains and ovaries in perimenopause is just not, I just don't know that we're giving them that understanding and that education as much as we should be.
Right. So they got to read the book.
Yes, exactly. Read the book. I should have got mine is front and center up by where I talk to all my patients, my list of have tos. So
clinicians should read the book too, because I feel like up until this annual meeting, people were finally starting to accept that we can treat women in perimenopause with hormone therapy, and you weren't doing anything bad. You were giving your patient a trial. They come back a few weeks later. It's working. Great. It's not working. Great. You change things. But I feel like they shut that down at this annual conference. And I really feel like we've gone back a step or two now, which is so concerning. And clinicians who were just getting a handle on using hormone therapy are now, okay, so the pill is the way to go. And we see all these women who do not feel well on the pill.
That's right.
So I really feel it set us back. It's so unfortunate. And then you go to, the one you're going to go to, what is it, for A4M or Ishwish? So forward thinking, so centered around the patient. Your patient will tell you if this is working. Listen to your patient, believe your patient, not you are the professional, you stick them on the pill. And that's the end of it. And no talk about the difference between the pill and hormone therapy. Hormone therapy is way more natural, tiny, tiny doses, doesn't shut down your own ovarian function, and we're not idiots. We know that the pill is amazing and is so helpful for some patients. Yeah. And where would we be without it? We'd all still be barefoot in the kitchen, with 12 kids. So we're not imbeciles. We know that. But what happened this year was really unfortunate. I feel like I came away very depressed myself.
Well, I think too, if we, we've had this big push, which sort of fell off, about not calling it menopausal hormone therapy, calling it just,
What it is.
progesterone, estradiol, testosterone, so that we can normalize the fact that it's not just about menopause, because those PCOS patients, which there's a ton of, that we didn't talk all about PCOS. We didn't talk about PMS or PMDD, which are
I see a
all
lot of.
deficiency
Right.
progesterone. And so, and then, then I think the thing then providers are like, they'll put somebody on a birth control pill because, the one woman in the universe who is agreeable to it. There's not that many that are, and I'm being a little, whatever about it. But you put her on it and she comes back and she's still having brain fog or heart palpitations or joint pain or any of the other symptoms, and they're like, well, that's impossible. You cannot possibly be still having symptoms. You're on birth control pills. Well, it's because you shut down the natural hormone production from the ovaries. So there's nothing sitting on the receptor sites. So it's just, it would be so much more helpful that if we could just say the evidence isn't there, but the harm evidence isn't there. And this is what taking care of lots and lots of patients successfully looks like. We could help so many clinicians and patients.
Again, the message was just read the papers, and clinical experience means nothing. What your patient is telling you means nothing. Just read the papers and go by the papers. I mean, yeah. Very disheartening. So I think
I like that evidence informed, right? We give evidence informed care sometimes as well, not just evidence based care. We do both.
Yeah. For me, it was like being a cardiologist, going to a cardiology annual conference and every speaker getting up and you thinking, do they have some type of gag order on them where they can't talk about statins? And we're like, well, statins exist and they're okay and they won't kill you. But let's use lifestyle interventions first, at a cardiology conference. That's what it felt like to me. I was just laughable. So I think all clinicians should probably read your book as well, not just the general public.
Thank you. Well, yes, I am excited. I've been training other mental health providers. I've done a couple of presentations for groups of social workers. I'm speaking to psychiatric residents at NYU next week. So
Brilliant.
I just think, and to your point of what we were just saying, nuance is so important. Everybody is different. So the pill might work for someone and it might not for the other person, and that's okay. But we have to be open-minded about that and really listen. And I just certainly can say that mental health providers are not getting any training in this. So at the very least, I'm able to introduce them to this idea. And I am hopeful that more and more in whatever discipline they practice, that they will pick up the book.
Because we've become so siloed, haven't we? That all of our different specialties exist on their own and we're not communicating well. And these women are getting these $1 million workups for their palpitations when a 25 microgram patch might have gotten rid of them in 48 hours,
Yep. Oh, or they're ordering however many supplements from the internet and then not telling their providers about it. That's really scary and super common.
I just posted about that new, I don't know if it's a new app. It's new to me, SUP, SUPP, CO, and you can put all your supplements in and they rate them and then they analyze your stack to see if you are taking more than you should or less than you should, and to help you re-engineer your supplements. And I was a little surprised to see the quality of a few of the supplements in there. So I'll be making a few changes to my own supplement stack, but everything from Full Script had high ratings because they're third party tested, and they're credible. I just did a post on that. I'm like, put your supplements in, let's see what you look like.
Yeah.
That's really interesting. And tell your provider, please. If you're afraid to tell your provider about it, something's wrong.
Yeah.
About your supplements?
Yeah.
Yeah.
Not for you, but
we need to know. We need to know everything that you're having and doing and, putting in your body and
why you think you might need it.
Yeah, exactly. We really is, and so tell me specifically, obviously because you're a millennial as well. And is that, and we have just, they're the next ones going through perimenopause and starting to go through perimenopause. And so for when you wrote the book, Is that specifically kind of why you're like, well, listen, this is me already, so I already have a firsthand? I also think that we're the next up and coming after, our Gen Xers who have been so dang loud, and some of them, who are trying to get themselves back on or just initiating hormone therapy, because depending on where they are in the Gen X generation. And so the millennial generation coming up are really going to just continue to really move this forward.
I hope so. I really want my generation to be proactive, because all of the older women who I spoke with had a lot of regret about how they approached their transition, regret about not even knowing what it was and not having the right resources to get information or the right healthcare providers. And we cannot avoid menopause. That wasn't my intention, be proactive about it. It's being prepared with knowledge, with lifestyle changes like the strength training, like prioritizing sleep, stress reduction, social connection, and also to not be afraid of hormones, which the legacy of the WHI really is still with us. And all of my friends and acquaintances, that was their top question. Doesn't hormone therapy cause breast cancer? Or if I have a family history of blood clots, I'm not eligible, right? And so I really wanted to dispel the misinformation and have us be open-minded as we approach this phase as a generation.
That's awesome. And then in the teachings that you're doing for clinicians and in the mental health space, that's what's so important about that is that's where these women may end up showing up first, right?
And they do, absolutely. I feel like I'm on sort of the front lines, which is why it's so important to build that collaborative team, those referral sources, like we mentioned earlier, because women, they might go to their primary care, their OB once a year. They, as we know, don't feel like themselves, but not quite enough to make a doctor's appointment. Or even if they feel crappy, women, we know, put themselves last on the to-do list. They don't take care of themselves. But if they are feeling moody, or if they already have a mental health provider that they see somewhat regularly, that really is an opportunity to reflect and assess what's going on with you. You say you don't feel like yourself. Tell me more. And, of course, rule out other medical conditions. But again, that speaks to the power of knowing what perimenopause is and having that referral list.
Yeah, that's amazing. And tell us a little bit about your practice as far as seeing women. Where can women find you? How are you telehealth? Are you in person? Are you hybrid?
So primarily telehealth. I live in Westchester County, where I also do see women in person, but because we're all so busy, my clients tend to prefer meeting virtually, which works for me. And I'm licensed in New York, New Jersey, Connecticut, and Florida. And I do these kinds of trainings and speaking, engagements all over. And it's really, really special to meet with women wherever they are, physically or emotionally, and to be able to connect and support them.
And how can our listeners find you online, Lauren?
So I'm on Instagram as the counselor, but LAUR for Lauren, as you can tell from that. And the book, I love cheeky puns. And if you go to millennialmenopause.com, it will bring you to the list of bookstores. Wherever books are sold, you can find the book and my upcoming list of events. So come say hello.
Yeah. It's been such a pleasure having you on today. Thank you for joining us.
Thank you. I hope I see you all soon.
And that's a wrap on today's conversation. Proof that brains, heart, and humor really can coexist in one human. If you're not already following Lauren, do yourself a favor and fix that. She's out there making women's health smarter, braver, and a whole lot less hush-hush. If you loved this episode, share it with a friend who's still trying to figure out if it's her hormones, her job, or just the patriarchy. Spoiler, it's usually some of each. Don't forget to rate, review, and subscribe to the Dusty Muffins wherever you listen. It helps more women find evidence-based truth without the fear-mongering fluff. Until next time, stay curious, stay vocal, and never let anyone tell you midlife is a downgrade.